One thing in particular I touched upon in my talk is that we live in the post-Aquila world where patients with smoldering myeloma may go on to receive therapy as standard of care. This is obviously very new to everyone, but it also has implications as far as genomic biomarkers and immune biomarkers for that matter are concerned. Specifically, we should not be assuming that genomic biomarkers that are relevant in the smoldering myeloma setting are also relevant in the myeloma setting and vice versa. And there are many possible explanations for that. It could be due to the current therapeutic options being as effective in mutant versus wild type individuals, could be changing biology with advancing disease, and of course could be technical reasons like our power to identify such variables. So I think it's important for everybody to take away that abnormalities such as deletion 17p, which we've known for many years to be adverse risk factors in patients with myeloma, may not be coming up in our smoldering myeloma models, but that does not mean that they do not confer high risk. This is just something that we need to keep at. And of course, we need a more extended list of biomarkers to cover patients with smoldering myeloma who may receive therapy or may, in fact, be observed. Moving on to immune biomarkers, I discussed some of our single-cell RNA sequencing data, where we were able to show that there's increased clonal expansion of cytotoxic T cells, as well as increased interference signaling in immune cells in patients as they progress from MGUS to overt myeloma. And so we can also start thinking about how we can better understand these mechanisms in order to incorporate these as biomarkers in our models, envisioning a future where our risk stratification and our clinical practice is truly biologically informed based on tumor and immune biology.